Over to you, Debs. Thank you.
Great. Thank you, everyone. Hopefully everyone can see my screen and can hear me. Thanks. My name is Debashish. As I mentioned, I'm a consultant cardiologist. I founded Ortus for the exact reason in 2017 as a eager registrar at the time. My boss and clinical leader happened to be the CEO, which was helpful. And when I gave him the idea, he kind of said to me, "Debs, I don't know what you're talking about, but give it a go." And it has led to 7 years down the line, and we are here today. I wanted to show what happened basically from post-COVID and what's really led to the expansion, as most people have heard since then, that the more of the use case of kind of remote monitoring and cardiac virtual wards. But the challenge that was set across London was first in line from kind of cardiac surgery as the primary driver. We have on average about 1,800 to 2,000 patients waiting at any one point in time in London. We were seeing post-COVID increase number of our P2 patients and longer waits. And we were worried that we were going to go back to the older kind of days of patients coming to harm due to kind of long waits. NHSX was involved in this project and put £750,000 worth of NHSX funding to cardiac networks to see whether remote monitoring could potentially help risk mitigate these patients. So this is what we were seeing across London. These are some of the reports that we do on a monthly basis, keeping a track of our wait across the various surgical sites. And again, what we were seeing was reduction of our business as usual activity, increase of our wait. We also track on each site the clearance times of the waiting list, so how long it will take each site to get through their P2s, P3s on current trajectory. And again, we were seeing increasing clearance times, all giving the rationale behind how could we risk mitigate patients, how can we bring potential patients forward who are deteriorating. So the idea was to remotely monitor those patients who are waiting for deterioration. But actually, on the offset, we wanted to really try and do an end-to-end pathway, focusing on the pre-hospital. But can we then, once we have these patients, be able to either bring them forward earlier if they're deteriorating, but also enable early discharge? So we very much up front, 2-3 years ago, had the thought process of having really stepped down virtual wards for these patients as well. So as you can imagine, these are all the centres that got together, and it's remarkable that we all got together and agreed, which is one thing, knowing the centres, but we also agreed that we wanted one solution and one pathway, a unified SOP for our cardiac surgical patients across the sector. But bearing in mind, knowing that once we do have a unified remote monitoring solution, cardiac surgery was always just the first pathway that we had in mind, and hoping that bringing something like this would spur on other innovation. So in December, there was a procurement process. Each site had their own kind of remote monitoring solution, but there was a want and a need to unify it. So rather than a fight between each centre, they went through a procurement process, and Ortus was chosen. And Ortus really is it's a remote monitoring, a virtual solution, but it also tries to digitize much of the journey as well through pre-assessment forms, proms, digital content. There was a high degree of technical specification that was wanted in this part of this, that not only to help remote monitoring, because we know that remote monitoring of virtuals is more work for our staff, but could we release some efficiencies through digitization of other parts of the pathway that would then offset the increased work that remote monitoring would do? And that's what Ortus tries to do. It also allows easy, quick configuration for different virtual wards or different remote monitoring lists very quickly, such that you can see your quantitative data, be it observations, but a lot of our virtual boards are more reliant on qualitative data, symptoms reporting. And in fact, different symptoms are important for different different virtual wards that we have. So each list we can create algorithmic based questionnaires specific to your pathway that would highlight deterioration, and deterioration specific to the symptoms of your choice. So our heart failure virtual wards will have a different algorithm questionnaire to our cardiac surgery or to our end-stemic. And within that virtual remote monitoring, you have all the tools to be able to try and manage these patients as asynchronously as possible. Some of our centres were already doing remote monitoring, but through telephone. And we know that takes time. What we didn't want to create was more 111s out there across the centre. So how could we utilise the tools to gather as much information, clinically relevant information as possible from patients, but then manage these patients asynchronously through the messaging functions? So we unified an SOP across all cardiac surgical centres, asking for patients to submit our cardiac surgery questionnaire with a specific algorithm set for deterioration. Stable patients would be highlighted as grey, and those deteriorating based on the algorithm, amber or red. And they will be remotely monitored by our AMP staff on a weekly basis. Any red flags would be reviewed by the AMP and then escalated if they felt appropriate to the responsible cardiac surgeon, and then expedited to surgery. And as I mentioned, we took the opportunity in these pathways to digitize other components of it through pre-assessment forms, content for the patient. So at BART, the cardiac pre-assessment pack that was often given to the patients are now sent through the portal digitally. So what did we do? As you can imagine, this is a large-scale project delivered in what I would say quite a rapid time. So we went live through each site within kind of 6 to 8 months, and we have, this is slightly old data now, but it's over 8,000 patients have been put through the pathway, and in London we have had over 432 patients escalated and brought forward for surgery in 2 years. The pathway was evaluated independently by UCLP, and these are some of the key findings that came out. So the primary objective of the pathway was achieved. We were able to, through remote monitoring, identify patients at risk, deteriorating, and bring them forward for surgery at scale. We were able to analyse that actually those who engaged with the pathway and were remotely monitored were less likely to become an urgent unelective case, i.e. landing up in accident and emergency. And those who were brought forward through remote monitoring fared better than those unelective cases brought in by the front door. And where there was remote monitoring already done through kind of telephone, through the asynchronous method, we were cost effective, £345 per patient via this pathway. Now, of course, I've just highlighted all the positives, but there were negatives, and largely a lot of the negatives were through implementation and communication with patients that we have and we are subsequently continuing to address. Our method for rollout was very much, this was an urgent thing to be done. So we've taken an agile process to delivery, learning quickly where we're making mistakes and adopting them. And a lot of the key to success for this is really good patient communication, letting know the patients what the pathway is about. And that's what our focus is on now. This is business as usual, but really trying to take where we have 80% patient activation and engagement, we're trying to bring that further as much as possible, close to 100%, with a motto, leave no patient behind. So what has that then done? And it has inspired other pathways across the sector in London, of which you'll hear two more today. It's also blurred that gap between cardiac surgery and cardiology. We treat these patients as one and the same now. They're cardiac patients. We've had various new pathways, from low-risk end-STEMI pathways, monitoring our aortic dissection. We have atrial fibrillation virtual wards through PPG monitoring. We have long-term condition now remote monitoring across different sectors through cardiomyopathy or inherited cardiomyopathies and so forth. And we've just set up in BART our grown-up adult congenital cardiac disease remote monitoring and virtual wards. So that's a whistle-stop tour of what we've done so far. If there are any questions, I'm happy to have him afterwards.
Thank